Good morning, this is Peter Petros. I will be talking about the tethered vagina syndrome. It was first described in 1990 as part of the integral theory. It is scar-induced massive urine loss which can be cured by skin graft to the vagina, and it is an important proof of the integral theory. Tethered vagina has two phenotypes, iatrogenic from vaginal surgery and Burch from obstetric fistula. The cause for both is scar-induced tightness in the bladder neck area of the vagina. For number one, iatrogenic, classical symptom is uncontrolled urine leakage when the foot touches the floor, getting out of bed in the morning. Previously, this was called motor detrusor instability. For obstetric fistula, the leakage is constant all the time. Treatment for both: free all scar tissue from the vagina, urethra, bladder neck, and restore elasticity in bladder neck area of vagina by skin graft. This is what it looks like with the iatrogenic scarring. You can see a scar tissue exactly at bladder neck. Transperineal ultrasound is very useful. You can see there's very little movement on straining at bladder neck. Very little movement. Rest straining. The anatomical basis for tethered vagina syndrome is that the three opposite reflex muscle movements, forwards, backwards and downwards, require elasticity at the bladder neck area of the vagina so they can close the urethra separately, then close the distal urethra and close the bladder neck. You need elasticity, and it's called the zone of critical elasticity in bladder neck. So scar tissue at the zone of critical elasticity tethers the posterior muscle forces to the anterior. So instead of these closing the urethra here and these closing the bladder neck, these just pull these backwards and downwards to open the urethra, resulting in massive urine loss. The posterior urethral wall is forcibly pulled open, there's a posterior urethral wall, and urine flows out uncontrollably. So testing for iatrogenic tethered vagina syndrome, you ask the patient to cough. Generally, very little urine is lost. But if you put your fingers behind the bladder neck and stretch it backwards, you remove the residual elasticity here, and it provokes a large amount of urine loss on coughing while you're stretching it backwards. So the first step in surgery of tethered vagina syndrome for both types, you dissect the vagina clear from all scarred adhesions. So you dissect the scar here and you put some sort of skin graft here, direct, or, as the case here, skin on Marsh's graft. And here is data from Professor Gershon, an abdominal skin free graft applied directly to the space, 52% dry. But he used a skin on Marsh's graft which has its own blood supply, and the result was much better, 78% dry. Dr. Browning augmented the zone of critical elasticity here with a skin on Singapore graft. It's a larger graft taken from the thigh, and it of course has its own blood supply. Results from Dr. Browning: in GO-type fistula 4, the worst type of fistula, using it prophylactically, he achieved 46% dryness, and the expected cure was 19% using previous methods. And in patients who had continued severe leakage after successful fistula closure, he achieved 71% dry, and it was an expected rate of 26%. Thank you very much.